I would like to introduce you Dr. Albert Canturri that joined us as a pathologist in our lab recently, that was a few months ago. He is a DVM from Europe, from Spain, and I'll let you introduce yourself better than me.
Yeah.
Thanks, Albert.
Yeah.
Floor is yours.
Good morning, everybody. Very quickly, I got my DVM in Spain. I'm originally from Andorra in Europe, and then I got my DVM in the University of Zaragoza in Spain, and then I did the residency in pathology and anatomic pathology in the University of Barcelona. Also in Spain, I became board certified by the European College of Veterinary Pathologists, and then I came here to do my PhD at the University of Minnesota, and as Fabio said, I am the new recruit of the lab. So today I wanted to talk to you about the value of histopathology and how maybe histopathology is the most valuable diagnostic tool that we have, at least in my opinion, and I will try to sell you this idea. So this is the outline. So to me it was very important to give you a little bit of familiarization of what we do and when we review slides, right? When we look into the microscope, what is what we do, because sometimes it's hard for you to understand or for you to know how we go from the lung of a pig to the slide, right? So I would like to give you a very quick idea of how we do this, how we process the tissues for histopathology, good practices for correct histologic evaluation, so things that you can do in the field to help us be more productive and more helpful to you. And then this is the bulk of the presentation, or I will spend most of the time talking about examples of how histopathology is most useful or even required for disease diagnostics, and then my vision of the present and future of histopathology. So we have been using microscopes since the 15th century, more or less, but it was not until 1673 that Van Leeuwenhoek developed the first microscope, or the more developed microscope, and reported the first microscopic observation. So this was the first microscope that was used. So this is the lens. The lens was the size of a grain of sand, and then you would put the sample here in this needle, and then you would approximate that microscope to your eye. And this is the highest resolution that you have. These are human sperm cells. So apparently Van Leeuwenhoek had, a preference for this type of sample. Then that microscopes were further developed in the 1830s, and this was a revolution in microscopy. And thanks to that, in 1838, we have the first book on histopathology. So it was in the Nature of Characteristics of Cancer. This is the first book, and from that moment, it became more and more popular in the medical field. Formalin, the fixative that we use more frequently now, it was first used in this year. And then in the last century, we had abundant advancements. We have histochemistry, electron microscopy, immunohistochemistry in the 80s. And in the last decade, we have digital pathology and artificial intelligence in pathology that I will talk more at the end of my presentation. So, even if it might be the oldest of the diagnostic tools, we, as pathologists, we spend most of our time looking at in the microscope, right? Looking at histologic light. So it means that it's a very important tool, right? And it has not been replaced by other more newer diagnostic tools. So histopathology continues to be the gold standard because it does a job that is very important, and it's to assign or to describe lesions, right, and to assign pathologic significance in lesion evaluation. Okay. So this is very, very quickly from, I want to go from the fresh tissue. So this is a lung of a pig that you can have in the, when doing a necropsy in the field. We take samples of this lung, and then we put, and I will show you later what are the good practices of selecting the good regions of the lung, and we put that in formalin fixation. I put here a box of formalin, and I would loft. So in an ideal world, every farm or every site would have formalin. There, maybe not a box, but a small bottle would suffice. And then the tissues are fixed, right? And then we do this is when we get to the lab, and we put these tissues, so we further cut them or slice them, and then we put them inside cassettes. So this is a cassette, and you see here what is the size of a cassette. So the idea, keep this idea in mind that we are going from something very big to small and small, so it's very important to do a good selection of what are the tissues that we are doing, right? So then this goes through dehydration through a series of alcohol, and then we put paraffin. So this is the paraffin embedding phase of that. So it's a liquid wax that when it gets solid, it's very hardened. So this is the paraffin block. You see that many different tissues here, and this is the paraffin wax that is solidified. And then we go to the microtome section. So we put this paraffin block is here, and then this is what we do. Okay, so we slice that, and we take 4 micrometers in thickness sections of that, and then we do water bath fishing. So we place this section into a water bath, and then with the actual glass slide, I call that fishing. I don't know if it has a more technical name, but we fish them, and then we rehydrate, and we do the H&E staining, and then we do microscope evaluation. So this is what we do in the lab every day. Very important idea, again, we go from something very big to something extremely small. So it's like reading a paragraph from a book that has 1 million pages, right? So it's important to know what page or or to do a very good selection of the tissue. So good practices for tissue sampling for histopathology. So the first 3 are, normal or they are also for necropsy. So good animal selection, right? We need to select the animals that are more representative of the issue that we have in the farm. Acute stages of disease are better than chronic stages, and let's put more than 1 week. Okay, ideally 3. For us to evaluate lesions. And this is very important. So for histopathology, we need fresh tissues. Animal decomposition of autolysis is very important. So aim for recently dead or even euthanized animals for us, and put them in formalin, especially when you're dealing with, and we will see that later, in intestinal diseases, right, enteric diseases. Include clinical history and necropsy findings. If we do the necropsy, we will, have a look at the gross lesions, but if you do the necropsy, please include the gross lesions of what you have seen. And this is the tissues that we would like you to send us, right, fixed. So when we have a gross lesion, like in this lung that has cranio-ventral consolidation here, ideally we would like to have an area of the suspected lesion, an area of the normal or apparently normal lung, for you what is normal, and then an area of transition between normal and abnormal, okay? If you don't see any gross lesions, samples can be taken randomly. And then for tissue fixation, that's also very important. Formalin penetrates tissues at a rate of 1 millimeter per hour. So slices or thin cuts work better than cubes. So for example, this is an example here. So if formalin penetrates like this, if we take a cube of tissue, when the formalin reaches the center, the tissue, it takes 10, 12 hours, the tissue is already rotten. And contrarily, if we take slices, the fixation is much quicker and more homogeneous. And that's a very important statement, and it happens to us every day also. So don't overestimate your clinical or gross diagnosis. So something can be or can point you to a direction from the clinical point of view or from gross diagnosis. This lung, for example, has a very clear lesion, but do not focus on just this. It's a good practice to obtain a routine set of samples for histopathology, and these are the organs that I include always in my necropsies, okay? So an example of that is, for example, when you have an outbreak of PRRS in a sow farm, maybe the first clinical signs are piglet diarrhea, and then we do an enteric workup and we don't see anything there. So if we have the lungs of those piglets, we might see interstitial pneumonia that would point us to PRRS infection. So it's very important to have everything. And now I'm starting to, I will start to show you some of the examples of histopathology, and in examples in which histopathology is very valuable or even required, right, to reach a diagnosis. But when I talk about diagnosis, so I think it's very important for us and for everybody to do this, or to differentiate these two terms, right? Because there is a lot in a word, and it's good to, because I think ourselves as pathologists and people out there, I think they are misinterpreted very frequently, and they are confounded between themselves. So if you take a look at the microscope, at the dictionary, you find that diagnosis, one is the determination of the nature of a case of disease, and the second one is the art of distinguishing one disease from another. So I prefer this one because I feel that I'm an artist, and so I like this one better. And in the contrary, to detect is just to discover or determine the existence of something, right? So it's important to know that diseases are diagnosed and microorganisms or viruses, toxins are detected. So when we talk about molecular diagnostics, which we do, maybe what we should talk about would be molecular detection rather than that. Because as we know, PCR detection is great. Okay, it can give us a lot of information, but it's just that it's a detection of something. It needs context. It needs other, it needs the interpretation of the clinician, the interpretation of a diagnostician. It needs sometimes other diagnostic tools like histopathology to reach or to become a diagnosis. Okay. So, and part of the problem between detection and diagnosis is that more recently or increasingly we have multiple detection of viruses and bacteria, and some of them are pathogens, some of them are pathobions or commensals, and this, we do this every day and increasingly in a diagnostic lab. So I made up an example here, and this is a made-up example, but it could be real. Let's say it's a 7-week-old pig with the histories unspecified respiratory signs. And we have the detection of all these pathogens, or all these pathogens, right? We have birds. I made up the cities are made up, right? City of 28, influenza was not detected, PCV2, PCV3, parvovirus 2, Mycoplasma pneumoniae, and then we have also bacteriology. We isolated, let's say, Strep suis, Pasteurella multocin, okay? So that's very good information, very valuable information, but we need something to ponderate and what is important, what not, what is clinical, what is subclinical. So I think the value of histopathology is that it sorts the chaos, these chaos, it sorts out these chaos, okay? So when we look at the microscope, these are the diagnoses that we do, detection versus diagnosis. Imagine that we had an acute, multifocal, very incipient, very initial pleuritis, venosuppurative pleuritis. And that was not visible microscopically, maybe. It was just visible under the microscope because it was in the very incipient stages of development. We have suppurative pneumonia, and we have bronchiolar epithelial hyperplasia, okay, which is chronic. And this is where we come with this information, and with this information is where the pathologist or the diagnostician does the interpretation. And one possible interpretation would be maybe there was a swine influenza virus infection some time ago, that since swine influenza is very rapidly cleared from the system, it's not detected here, but it opened the door for secondary bacteria to appear and to produce a pleuritis and bronchopneumonia. So the main pathogen here, or the key of this diagnostic, is something that we have not seen. We didn't detect it here. So I think it's important. This is just an example, but I think it's a great example of how histopathology can help you in the diagnosis. One other example, and endemic bacteria are problematic, at least in my opinion, because they are just there and they are not causing disease, but they can cause disease, right? They can become pathogens. So we have several examples: Mycoplasma hyraini, Streptococcus suis, Glasserella parasuis. They are common inhabitants of the tonsils and upper respiratory tract. So when we do an necropsy, and if we start, cutting the lungs and contaminating the surfaces, contaminating the knives, not contaminating, but just allowing them to be with the knife, with the scissors, etc., we can contaminate our materials. And then imagine that we have a swab, and we take a swab from, we cut the head, and we take a swab of the brain, and we isolate Streptococcus suis, for example. Well, that might be a non-pathogenic strain, right? So we need to correlate the lesions. So this is a suppurative meningitis in a pig in which Streptococcus suis was isolated. So we need to correlate the histopathologic findings to that isolation to make sure that we have a pathogenic strain in the case that we want to do an autogenous vaccine with that. Another example, and I mentioned that before, a list of pathogens that were just detected, okay? Many of them, and the pig didn't show any, or it was subclinical, right? Many pigs are PCR positive to many viruses and can harbor many bacteria, but they are clinically healthy and there are no lesions associated with that. So one example, and this is pretty extreme, an extreme example of this, and this is a lung of a pig with interstitial pneumonia that has necrotizing exudate in the alveolar lumina. We have free chromatin. So this is a clear example of interstitial pneumonia caused by PRRS, and indeed we had PRRS detection in this tissue homogenate of CT of 19, so very low CT value, so easy, simple. And then we have this lung that apparently, it's very dissimilar to this one. It's very different. So it has no very significant lesions or almost no lesions. You see that these are the alveolar septa. They are not thickened. So one could say, well, no lesions here. Let's get to the other pig. But then you get, and this case is real, so you have a PCR of 21 in this case. So it can happen that maybe this sample was not the best one, or this part of the lung was not the best one to see lesions associated with PRRS. But it can happen. I couldn't do, I couldn't say interstitial pneumonia caused by PRRS because I didn't see just the PRRS, but the PRRS was there. So important to do histopathology and to see how histopathology can change the interpretation of PCR values. As a starting pathologist, I think that my life as a pathologist would be easier with PCR CT values always lower than 20 and always higher than 30, and nothing in between. That would be great, but it's not the case, right? We have a scale of grace, and it's very difficult, and I think it's the value of histopathology resides, and the interpretation of the pathologist is most valuable there, right? In those 25s, 22s. And a great example of that is rotavirus. So this is a normal intestinal villi, intestine of a 3-day-old pig. You see the length of the villi in comparison to the ribs, so normal. You see good preservation of the tissue, so that's what we want to see. And this is a rotavirus infection with rota A, B, and C. And you see that the length of, so there are almost no, so there's the atrophy and fusion of intestinal villi. You see that here, so the ratio between crypt and villi is very reduced. So easy, but it's not always the case. And there is a lot of grace in between those two. And it's extremely important for us in these cases to have fresh tissues, because if not, we cannot do a good diagnosis. We cannot do a good job, we cannot help you. So in those piglets that have piglet diarrhea, consider euthanizing piglets, sending us or fixing the intestines right away, because we have seen that in 15 to 30 minutes is already too late for us to make a good diagnosis. In these cases, for example, if you suspect of enteric viruses, it's maybe good, we normally in a necropsy, we tend to do the digestive system at the end of it because, to prevent contamination with bacteria to the other organs. In these cases, it may be good to start with, if we have a very clear clinical suspect, it may be good to start with the intestines. So, detection versus diagnosis, I think this is, these examples have been made already. Histopathology is also good because there are some examples that they require some histopathology. So in the cases of nervous system, in the cases of toxicities, deficiencies, this is a bilateral symmetrical polyencephalomalacia, so selenium toxicity. nervous system lesions are grossly, they are very hard to see or very hard to determine, so we need histopathology on nervous tissues and nervous lesions. Neuropil localization, this is a recent paper that we did in which we just saw this neuropil localization associated with wasting peaks. So these are examples of required histopathology. Muscle, for toxicity, skeletal muscle necrosis, we require that. We require histopathology. Bone disease, increasingly common, at least for us. I call that, we see the growth plate. There is an expansion of the hypertrophic zone of the growth plate, retention of cartilage here, among many other changes. I usually call that, because I think we don't have a good name just to put everything together, I call this metabolic bone disease, vitamin D deficiency, phosphorus, calcium imbalances. This requires histopathology. Other things that require histopathology, Mulberry heart disease, right? So there is irregular distribution of blood, perimortem and postmortem, so sometimes it's very hard grossly to see or to know if this is Mulberry heart disease or not. But if we do histopathology, we see hemorrhage and necrosis of myocardiocytes, this can be confirmed. Again, circoviruses, circovirus 2 and circovirus 3, they require histopathology because these are the diagnostic criteria that are already published, right? So in order to differentiate between PCV2 systemic disease versus the subclinical infection, we need to fulfill these criteria. So we need to see clinical signs, failure to thrive, dyspnea, and many of them lymphadenopathy. But it's extremely important that we need to see the characteristic histologic lesions. So lymphoid depletion, as you can see here, if you're lucky and there is, PCV2 is in great content there, it's hard to see, but there are inclusion bodies in some of the cells. And we have to associate the presence of lesions with the presence of virus, so immunohistochemistry or in situ hybridization in lymphoid organs. These are the diagnostic criteria. Without these, and especially without the histologic lesions, even if we have low CT values, it's conceptually not possible to diagnose a circovirus type 2, and a little bit the same of type 3, right? So histologic lesions, multisystemic inflammation, arteritis, multiorganic, this is the heart, which is, we see arteritis here, this is the spleen, arteritis. And if we can confirm that by direct direction methods, like EASH in this case, this is another value of histopathology, right? That we can associate the presence of the virus with the presence of the lesions in the same place. But histopathology is maybe not, the panacea, is not great for everything. So there are some diseases in which we require ancillary testing, right? And, I'm using another example of nervous system. We have porcine teshovirus, astrovirus, and cephalovirus. They all produce the same lesion, and these are 3 examples of them. So right now, for me, it's impossible without the PCR testing to know which virus causes what, because they are extremely similar or almost identical. So this is the result. This was a teshovirus, this was a cephalovirus, this was an astrovirus type 3. But for us, it's impossible to know which one is it if we don't do PCR. The same with the polyserositis, right? So we see fibrinous pericarditis, pleuritis, and in the microscope we see this, I think it's a fibrinous suppurative pleuritis. It's impossible for us to know without bacteriology which one is it. So we need bacteriology in these cases or PCR testing. Other examples, very quickly, we can provide many more information. We can provide information about the chronicity of lesions. As in the example before, that pleuritis was very initial, very acute, or peracute, very incipient. So we can give you that information. Severity of lesions, mild, moderate, severe. Again, confirmation and localization of a lesion with a lesion. And I think histopathology is like a lighthouse. When we are completely lost in the field, when, unclear clinical signs, sudden death, we do the necropsy, we don't find anything relevant, or at least we don't see anything, let's do histopathology and see what we see, okay? So, present and future of histopathology, for me, it's now, the role of histopathology in the diagnostic investigation now is more important than ever before, because we have had a paradigm shift in the diagnostic investigation. So this was the past. So this was the chain in which we discovered things in the past, right? So there was a pig that was sick in the farm, so clinical disease observation, and that was clinically relevant, right? A pig that is coughing. Okay, let's see why is that pig coughing. Then we do histopathology, and we see that, of course, that pig has lesions, and that those lesions are important, so we can assign pathologic relevance through histopathology to those clinical observations. And then we will do, classically, pathogen characterization. Let's see that lesion that we have seen already, what is the causing factor of that? And we do electron microscopy, immunohistochemistry, in situ hybridization, experimental infections, etc. So this is the classic path in which we continue working, but this was the only path, the only chain in the past. While in present days we have the metagenomics has been much more available to use for us in pigs and in animals. So the first step is pathogen discovery. So the last step here in the past is now the first step. So we discover the presence of a virus or a bacterium, for example, most commonly viruses. And then we need to see, well, is that virus producing something in the pig or not? It's just staying there. So we need to do histopathology to describe lesions. And colonization versus infection. Is the animal, are the lesions, is that virus causing something in the pig or not? And we associate that pathogen to lesions. So we associate, or we give pathologic relevance to that discovery, right? And then what we have to do is to see, and sometimes it happens, I think PCV3s are a great example of that. We see that those lesions are causing something clinical to the pig. So is there, a decrease in growth rate? Is there clinical signs, etc.? So it has shifted the paradigm. And this is my last slide. What is the future of histopathology? This is debatable, but these are more common, common opinions that we have. Artificial intelligence, as we saw yesterday in log evaluation of lesions in a slaughterhouse, it's here. So maybe in the future the pathologist will be replaced by a computer. I hope not, but maybe. But we have used artificial intelligence in tumor staging, scoring, toxicological pathology. Maybe it comes to diagnostic pathology too. And digital pathology and telepathology. So now we can do necropsies via video call, millions of kilometers, thousands of kilometers away. We do slide scanning. We don't need the microscope anymore. We just need a computer. So maybe in the future, the service pathologist will work fully remote. I don't know, but it's a possibility. So with that, I would like to thank my fellow pathologists at the VDL and so my former boss, Joaquim Sebales and Javier Asin, which I asked them, give me some of your examples for histopathology, the value of histopathology. Thank you.
Thank you, Albert. That was great. That was great to show the complexity and the histopath as an important piece of the puzzle and the diagnostic investigation. Questions for Dr. Canturri? We may have time for one or two questions. Oh, I may ask a question then. So I'm interested on your thoughts on which seems to be more and more frequent, that we come up with more and more testing, PCR testing, and the ability of detection of different types of pathogens in the same animal or in the same case. And the first example that you gave, the chaos that you had there, and you have different types of lesions on that. So I'd like to, if you can expand a little more how you sort that out when you're looking at the slides and you were, or more important, when you are translating what you're looking at to the vet. Bronchopneumonia, and you got interstitial pneumonia, and you got a bunch of PCR. How is your thought process on explaining, here's what I think is a primary trigger, and here's what I think is going on, which will depend, the time course of the animal they're collecting and so forth.
Yeah, good question. So first, and this is maybe personal, but I look at the slides before looking at the PCR results. Because, of course, we are humans, and we can be biased by the detection of those pathogens. So it's very important, at least to me, to look at the slides without knowing what was detected there. You have to have a plain idea of what is going on. And then you assign the lesions, you write down. I think it's good to do a description of the lesions for the, for the veterinarians to look what we have seen, if it's mild, moderate, severe, etc. A brief description of that. And then and this is where experience, years of experience and knowledge comes into play, right? So my idea is to give the lesion description and assign that to a detection. And if not, I put that description and then I list the veterinarians know what has been detected. But the real value of us, I think, is in the comment section of the result interpretation. It's our interpretation and it's what the veterinarians look at there. One clinician back in Spain told me once that when I see that the pathologist writes more than 2 sentences in the comments, it means that has no idea of what's going on. So I try to keep it short, but sometimes you cannot keep it short because there are, as you see, a lot of chaos. So I think it's good for us to explain what's there, and sometimes, pick up the phone and say it by words. I think it's even better to say, look, I have seen this, and this. Sometimes very clear, sometimes I don't know what's going on. Send me more pics. So I think communication is key. But yeah, explaining things to the vets.
No more than 2 sentences.
No more than 2 sentences.
And I learned that when you write down something about multifactorial, they said, oh, you have no idea what you're talking about. Well, one quick question here in the back.
Thanks. Anything going on in the world of alternatives to formalin? I'd be quite keen to have a dry powder you can take with rather than hauling around volumes.
Yeah. So that's a good question, and it has been, so for example, I know in Europe, it's becoming more and more difficult for field veterinarians to have formalin in their trucks because of the health hazards that formalin has. And there has been a lot of research on that, but we are not using anything else because we have not seen a good alternative to formalin. There are other fixatives, wind fixatives, or some of, for example, we know that for eyes, formalin might not be the best option, so we have other fixatives, but they are all the same, in terms of health hazards that I know, they are all the same problem. So I think there is people working on that for a long time, but I have been having that question myself for a long time, and I don't see an alternative right now for formalin.
Dr. Albert will be around in the next day or so. You feel free to stop him and ask. We really need to move along due to the time. Thank you, Albert, again. Appreciate it.